So there are many things one can say about vaccines. I think this audience is more than well aware vaccines are of paramount importance in preventing many infections that can be life-threatening. And my hope over the next 15 minutes is impress upon you the importance of this by discussing in some detail 3 specific vaccines. All have very different profiles, if you will, with respect to which populations and what timeline they're targeting. I think this, and I hope this will also give you the tools as we counsel our patients who are at utmost risk for the infections that these vaccines are preventing, specifically those with chronic cardiopulmonary disease, and who live in families with vaccine hesitancy. So my mission is to go through measles vaccine, which has a direct preventative infectious action for measles, and I'll give you a little bit about the history and how it works and why this is important and why measles should be prevented when we have an opportunity to do so. Then pertussis, and specific to the congenital heart population, it's important to recognize that infantile pertussis vaccines, which we do provide, do not actually prevent immunologically pertussis in the earliest timeline in the first few months of life, despite the fact that we give it then. And this, I think, is of critical importance for the understanding in the care of congenital heart disease patients, specifically infants. And then human papillomavirus, which is a vaccine that we are now giving in childhood, roughly 9 to 12 years of age, however, is most likely to be protective later in life. And then I'll make a few comments on vaccine hesitancy. So with no further ado, let's talk about measles. And the vaccine against measles is really directly to prevent the measles infection early in life. So if we go back to the 1960s in the United States, measles actually had a large impact on our population, with approximately 500,000 cases per year, resulting in 50,000 hospitalizations and about 500 deaths per year. It's important to note, especially in your cardiopulmonary population, that it was not only measles, but co-infection with respiratory viruses and bacteria causing pneumonia that was frequently associated with death. The other very sort of less direct and obvious sequela of measles is the possibility of encephalitis, which unfortunately usually results in severe brain damage in infants. What is also known is that there is a delayed entity called subacute sclerosing panencephalitis, which is a fatal progressive neurologic disease that usually develops 7 to 10 years after a measles infection. And this was proven in a study of this entity where all of the individuals who succumbed had wild-type measles prior to 2 years of age. Unfortunately, as the incidence of vaccine hesitancy and refusal is going up, so is the rate of subacute sclerosing panencephalitis, and this has become very obvious in Europe. So what do we know about measles? We know that the high-risk populations are young children, less than 5 years of age, pregnant women, which we have spent some time talking about, both of these vulnerable populations. And then, of course, the classically infected vulnerable populations of the immunosuppressed, folks with cancer, HIV, transplant recipients, and the like. So we know that the complications of measles are numerous. So pneumonia is the biggest killer. Encephalitis, I mentioned, as well as subacute sclerosing panencephalitis. However, what is also known is that the infection with measles causes malnutrition, which for anyone with chronic disease such as heart disease can be an additive complication. And then what is becoming increasingly recognized is that there is a susceptibility to other infections, specifically respiratory infections. So a relatively recent study was performed in 77 MMR unvaccinated children who had gotten measles just through a wild-type infection. And it was found that they had a reduction in their humoral immunity as long as 5 years after the infection, and were susceptible to infections because of this. So that was 1960. So move forward a couple of years, the vaccine is licensed. Then approximately a decade later, in 1971, MMR, which is a combination measles, mumps, and rubella vaccine, becomes licensed, which has really changed the paradigm of all three of these infections, and certainly measles. And by 2000, after quite a campaign of trying to eradicate measles in the United States, in 2000 it was declared eliminated from the United States. And this was really based on few cases, less than 100 per year. In the United States, it was typically less than 50, and this was sustained for actually nearly a decade. And then we get into the mid-2000s as vaccine hesitancy is coming out, and there are populations in our societies that are not vaccinated or under-vaccinated, and we start getting epidemics. And we know in the last couple of years there have been a number of epidemics in the press, including in communities such as the Amish at Disneyland, Somali American communities, and the Orthodox Jewish communities recently. And if we look in the last year, you can see that there are nearly 1,000 cases in the United States alone. So much like coronavirus, which we are currently dealing with, and everyone knows that we have to wear these masks, and 95% of us should be wearing masks to prevent community spread, so too it is with measles. And with measles, it is known that to get herd immunity appropriate with this vaccine, approximately 95% of the population must be vaccinated with at least 2 doses. And as a consequence, as vaccination hesitancy and refusal has gone up, and erroneous concerns about the measles vaccine has gone up, this continues to be challenged. So now we have over 1,000 cases in the United States alone. In Europe, this continues to increase, and unfortunately, the case numbers have gone up from being eradicated in the year 2000 to going up by 300% globally. Pertussis is a slightly different story. As you're all aware of pertussis and the respiratory complications of pertussis. The first outbreaks of pertussis were described in the 16th century, and in about 1906, the bacterial causative agent Bordetella pertussis was discovered. We now know that it's the 6th greatest cause of mortality due to infection in childhood, and it results in approximately 40 million cases annually and about 200 to 400 deaths annually. This is most prevalent in low and middle income countries, but unfortunately, this is rapidly rising, much like the measles story, in Europe, the United States, and many other countries. And if we look at the trajectory over time, you can see back here in the 70s, there were very low cases. We had a whole cell vaccine that was very efficacious. However, here in the 1990s or so, there was increasing concern about the safety of the vaccine, and consequently, there was a transition in the late 1990s to an acellular vaccine, which is still very effective, but not quite as effective as the whole cell vaccine. That, in combination, again, with vaccine hesitancy, we have seen a significant increase in the cases in the United States. Now let's talk about our most vulnerable population, and that is infants who are in the first couple of months of life. And we do vaccinate for DPT, which includes pertussis, in the first couple of months of life in the United States and most of the world at this point. However, a number of studies have shown that the antibody protection in the first couple of months, birth and over the next couple of months, is actually very low from this perinatal vaccination policy. And then this was really struck home on what to do about it back in about 2012 when the UK experienced a neonatal pertussis epidemic. And you can see this top line are children less than 3 months of age, and there are different ages in the lines below. So just later in 2012, in October, they came out with a maternal pertussis vaccine, and now vaccinate mothers in the typically early third trimester, 27 to low 30 weeks. And as you can see in doing this, the rate of pertussis in our youngest infants and other children as well did go down significantly. And in fact, maternal pertussis vaccination coverage in the first year is effective at 64%, and its effectiveness in infants in less than 3 months of age is approximately 91% based on many of these studies. So the Infectious Disease Society of America and many others have touted this as a recommendation for vaccination in early second trimester with DTaP, which is 85% more effective than vaccinating infants at less than 8 weeks of age. I'm going to switch again to human papillomavirus, which is relatively recently routinely vaccinated for at approximately 9 to 12 years of age. As many of you know, HPV is associated with almost 300,000 deaths per year. It tends to be higher in women in developing countries, and it is associated with many cancers of the cervix, vulva, vagina, pinna, and anus. Genital warts have a low risk for cancer, but are also very strongly associated with this viral infection, and oral cancers are on the rise secondary to HPV as well. However, what's interesting and maybe more problematic as we try to convince some reluctant parents to vaccinate their children with HPV is the benefit of this vaccine is actually quite delayed. So if one gets an initial exposure, which of course is going to be in late childhood or early adulthood, most typically, it could be 20 to 25 years later when carcinomas might be realized, and this all could have been prevented by HPV vaccine. I don't know if you've seen some of the TV ads recently for HPV. I think they're very effective. So let's just use the last few moments to try to understand this scenario of vaccine hesitancy, which in different parts of the United States and I suspect the world is increasing. So in 2010, there was an analysis of parents of young children ages 1 to 6 to try to understand what their views on vaccination was. And about 77% of these parents did have concerns about the vaccine. They were, many of them were simple concerns about the pain and fevers associated with the vaccination. How many vaccines were being done. About 30% did have concerns about possible associations with autism, which have not been shown in science, and that some of the ingredients of the vaccine may be unsafe. However, despite that, approximately 83% of the parents said that they were going to proceed with the recommended schedule, and about 11% said that they were planning to do so. So it's really the 7% of selective vaccinators or those who want to forego vaccination that we have to worry about the most and target with infection. So a couple of series studies have been done to look at parents and vaccination, and the National Immunization Survey was done in 2003 that at that time showed just under 22% of parents were intentionally delaying vaccines. However, this was reported repeated only 6 years later, and it was up to nearly 40% were going to delay or refuse at least one dose. And you can see that about 25% wanted to delay at least one dose, but almost 6% were either delaying or refusing a dose. And the delay and refusal were really associated with only a few things. They had a perception that the disease for which this vaccine was targeted was of low risk to acquire, or that the disease wasn't bad. And we've seen with recent measles, some proponents are saying it's better to build the immunity with measles infection and so on and so forth. So I think that is a misperception about the risk as well as the disease and how severe it can be. And then we have some that are certainly concerned about vaccine safety and effectiveness, and may have less confidence in the medical professional associations in general. And I do worry, I must say, as there's a lot of talk in the media about vaccination of coronavirus. If there is a perception that we are rushing these vaccines through or they may be unsafe, that may only worsen the situation that we're dealing with. So in summary, the vaccines to which the diseases to which these vaccines are targeted are very serious. Some of them are very serious and not only have implications for safety for the immediate infection, but sequelae of that infection down the road. And measles would be the prime example of that. Certainly any individual with cardiopulmonary disease and the populations that you care for, both the mothers as well as the infants, and those that are immunosuppressed. Vaccination is not important just for infants, but we have to think about vaccinating adults for their own protection, but in the case of pregnancy, also at times for the safety of their unborn child. And then where we do have individuals who do not vaccinate, we need to understand that for most of these infections, it requires a high rate, and about 95% of community vaccination for it to be safe. Failure to vaccinate obviously puts our community at risk. And I would say that as medical providers, every one of us, as we come in contact with children, mothers, and families, we are responsible for touting the safety and the importance of vaccines. And with that, I will stop.